Good evening and welcome all for our possible last CMA webinar. I'm sure you all had a great enjoyment or learning a lot about our webinars since the last 1 year. I'm sure till today, we offer more than 30 hours of CMEs under the guidance of Dr. Murthy. He did an excellent job and gave us a lot of educational seminars for us. Thank you, Dr. Murthy, on behalf of National Appeal members and the Executive Committee and Board of Trustees. Thank you. My first slide, please. Next one. COVID-19 pandemic, since last year, we fought very well as frontline workers and physicians and along with the nurses. And during last year, we lost several good friends, relatives, and great leaders of National API, particularly our past president, Dr. Ajay Loda, a dynamic leadership, and we lost him because of COVID-19. And also several other leaders were there in the slide. And I request everybody, please follow a piece of 1 minute silence, please. Thank you. Thank you. Next slide, please. As I mentioned that for the since last year, we got more than 30 hours CME credits offered through API as a membership benefit, and almost more than 40 speakers have been involved during this CME webinars. Most important thing, very close to my heart, we accomplished having our own journal called JAPI, J-A-P-I, inaugurated by our AMA President, Susan R. Bailey, and it will be coming every quarterly to our members. The clinical observership program has been initiated, and so far, quite a few number of medical students got educated through this program. And unfortunately, some of them also got some residencies through this program. So we are very, very proud of that. And World Restart Day program through the American Heart Association has been done this year. And community outreach program to GTV is very, very successful. Each time, the viewers are almost more than 1 million people are watching this program conducted by the API. Save a Blanket program is very successful. 30 API chapters was involved in this program. And Community Purified Water program, more than 6 sponsors donated money has been going to install in the state of Andhra Pradesh and Uttar Pradesh. Next slide, please. During this COVID in India, the second wave, our API members are donated more than 5 million in response to the COVID API COVID Oxygen Fund. And so far, we sent almost 2,038 concentrators to India, to various parts of the country, and 100 ventilators and 200 high flow oxygen has been going to be delivered.
Hello?
Yeah.
Yeah.
And also we are in process of establishing oxygen plants all over India. And telehealth platform, we are using 3 platforms so far. For example, eGlobal, very, very successful, useful to the patients in the remote part of the India as well as the physicians. Next slide, please. Thank you again for all the opportunity they gave me to serve this great organization. And without further ado, I request our CME webinar chair, Dr. Murthy, to go ahead with your program. Thank you, Doctor.
Thank you, Dr. John Laganda. Good evening. It's my pleasure to welcome you all to API's CME webinar. This will be the last webinar of our webinar committee during the current presidential term. We thank you, Dr. John Laganda, for all the support we received from you in offering CME programs with AMA PRA Category 1 credits of a total of 30.5 hours in an international format during the past 11 months. We also thank the leadership of the Chicago Medical Society for the CME accreditation. It's now my pleasure to recognize and thank the distinguished co-chairs of our committee, Dr. Naveen C. Nanda, Dr. Kalpalata Guntupalli, Dr. Rohit Vasa, Dr. T.S. Ravikumar, and advisor, Dr. Ranga Reddy. Their help and guidance contributed to the success of our programs. Thank you. Today's CME program is exclusively on COVID-19. We salute the fortitude and resilience of our members in managing the pandemic. We have two distinguished speakers providing updates on the pandemic in the United States and India as well. I will be moderating the question and answer session of 15 minutes after each presentation of about 35 minutes. Please submit your questions on the chat line. As we have strict time limitations, only few questions will be selected at random. I apologize in advance for it. Now it is my pleasure to welcome the advisor of today's program, Dr. Sampat Shivangi, who will be introducing our first speaker. Are you there?
Okay, I'm
Dr.
here.
Governor, are you there?
No, actually, she texted me just now. She does not have the link,
Okay.
Zoom link. I'm sending her now.
Okay,
So
fine.
let's go with Dr. Elnady to start with.
Okay.
Why not we do that?
All right. So I will introduce you, Dr. Shivangi, later
Yeah.
before you introduce the second speaker. Thank you all for your flexibility. Now, it's my pleasure and privilege to welcome our speaker, Dr. Vijay V. Eldandi. Dr. Eldandi is a specialist in infectious diseases with a special interest in disorders of the immune system, primarily recipients of transplants. An educator for his entire career. He is board certified in infectious diseases and is currently the head of infectious diseases and public health at Share India. He is a clinical professor of medicine and surgery at the University of Illinois at Chicago. His work over the last 3 decades includes laboratory research in antimicrobial resistance and molecular genetics, translational research, infectious disease diagnostics, clinical research in transplant infectious diseases, HIV epidemiology, antimicrobial development and clinical trials, and public health in India. Also, infection prevention and patient safety. His work in providing technical support to the National AIDS Control Organization of Ministry of Health and Family Welfare, Government of India, has been funded by the United States Centers for Disease Control and Prevention. He is a Fulbright specialist, and his work has been recognized by several awards of excellence in teaching and leadership. Dr. Eldandi.
Thank you very much for this privilege and honor to make this presentation to all of you. I will now start sharing my screen. So to begin with a short prayer, Lokaha samastaha sukhino bhavantu. In all of creation, may joy happen and let there be tranquility. This is an ancient Indian prayer. So the objectives of the presentation are to discuss differences in epidemic compared to last year, discuss the differences in clinical presentation compared to last year, discuss common treatment practices for COVID and clinical impact, and finally, what is Share India doing to address the COVID situation? My comments and remarks pertain particularly to India. Since the epidemic started in 2020, I've been helping to take care of a lot of people with COVID infections in India and also trying to address the COVID pandemic in a public health dimension. So compared to last year, there's been an enormous increase in the number of patients. What's true this time is that entire families are affected at the same time. So who's left as a caregiver? Everyone knows a friend, neighbor, or family member who has become critically ill or has expired. As compared to last year, there are a larger number of symptomatic people as compared to asymptomatic people testing positive. It's a larger proportion of infected individuals progressing from milder to severe illness, and a much more rapid progression from milder to more severe illness, what is called as telescoping. A larger proportion of individuals taking a very long time to recover from symptomatic illness with persistent elevation of markers of inflammation, what we call the long haul COVID, and also post-acute sequelae of COVID. So a very frequent recurrence of symptomatic illness in people a few days after stopping anti-inflammatory medications. And many individuals presenting after one dose of vaccine and some soon after a second dose of vaccine. A number of people having post-acute sequelae, chest syndromes, very severe tachycardia, very severe disabling fatigue, and also a small number expiring due to sudden death. And this is something that is not clearly understood in terms of what is causing it. In India, there's been an explosive increase in the demand for high-resolution CT scans, an explosive increase in the demand for remdesivir, and also an epidemic of what I consider questionable regimens: doxycycline, ivermectin, high-dose vitamin C, high-dose vitamin D, zinc, high-dose steroids, a lot of antibacterials, and also proton pump inhibitors. I've seen a large number of patients this year, specifically, with RALs in the lungs, very abnormal clinical examination, which I had not been seeing last year. And interestingly, anecdotally, most of these people have a treatment history of taking ivermectin and doxycycline with persistence of symptoms. There's been almost a complete collapse of public hospitals. And in fact, I heard anecdotes of patients being told that they should go home and try to obtain their own oxygen outside the hospital. And even public hospitals, unfortunately, are not consistently providing dexamethasone and anticoagulation to people requiring supplemental oxygen. So the questions that arose is, how is this illness caused by COVID-19 different from previous epidemics of SARS and MERS? As we have seen that despite the fact that the case fatality ratio is lower than MERS or SARS, the ease of transmission seems to be much greater, more contagious. The other question is, why does this epidemic grow so much out of control, particularly in India vis-a-vis the Western nations? So what is the difference between a first wave, a second wave, and is there going to be a third wave? Are very frequent questions that I get asked. I also get asked a lot about what is the role of mutants and variants, and will the vaccine work against new strains? Why are there so many deaths? Why is there so much lack of oxygen? Why is there a lack of hospital facilities and trained staff in India? And when will things improve? And what can we do now to address the COVID pandemic in India? And was the current catastrophe in India predictable, preventable? How, why? And can something like COVID happen all over again with some other pathogen? How and why? And what can we do to prevent something like this happening all over again? So these are some questions that keep arising, very troublesome questions. Unfortunately, we do not have very good answers for them. I'd like to draw your attention to some of the work that we did last year when we were asked to model how the epidemic would progress, particularly in the state of Telangana. So this is a model where we use what we call a susceptible, infected, and recovered model, where using the standard projections, we thought that we would see a little over the third of the population of Telangana infected by the fall of 2020. So the reality is something quite different. In fact, we were at that time criticized for projecting an overly pessimistic view when everybody thought that the lockdown was so spectacularly successful that the epidemic had essentially been controlled. Here's the reality. This is from just a few days ago. And as you can see, that the epidemic did not actually die down. There was a continuous inexorable rise. It had plateaued for some time in between December and February of this year, December of last year and February of this year. But somewhere in March, there is an inflection point in the epidemic curve, and there is an exponential increase. So why did this happen? Now, a lot of times we use a lot of very different modeling techniques to try and figure out what the epidemic dynamics might look like. And this can get quite complicated depending on the complexity of the model and the various factors that are used to put into the calculation. But I think that I would just point out some very simple things, a simple equation known as a logistic map equation. As you will see here, when the reproductive number keeps on rising, the epidemic curve changes. And as the R0 progresses and goes towards something like 3.44949 from any initial condition, the epidemic then becomes cyclical rather than linear, which means that it will keep on going up and down and then go back up again. And that is something that I think we have been seeing. I think that, in fact, last year, our projection of a R0 of 3 was overly optimistic, and in all likelihood, the R0 is much higher than 3 and probably in the range of 3.44949. And that is why I think that what we are seeing is the epidemic simply going up and down in a cyclical fashion. And once again, I think that in all likelihood, we will see the epidemic numbers decline in the following few weeks, followed by an inevitable rise in cases within months of the decline. Okay, and the reason for this is the logistic map equation. The only way to affect this kind of epidemic dynamic is the possibility that we have the ability to vaccinate over 75% of the population, including children. The probability of something like that happening within the next 6 months in India is very questionable. There are some significant concerns about the safety of the current vaccines in children due to the fact that children have a much more robust immune response. And it's also very important to understand that in India, children in the age bandwidth of 0 to 14 years constitute approximately 28% of the population. And we know from our experience that very often children easily acquire and transmit respiratory tract infections in children with relatively mild illness, but when that illness is transmitted to adults, they become much more seriously ill. And classic examples are mycoplasma and chickenpox, which in children are very often self-limited illnesses, although chickenpox can be lethal in children. But when chickenpox is acquired by a non-immune adult, particularly a pregnant woman, chickenpox is very frequently fatal. Now, this has very serious implications for schooling in India. Trying to rely on distance learning through the internet, like very often we have been doing in the United States, in India is absolute fantasy. So what we need to think about is that we need to prepare to take care of the affected people in the community rather than in the hospitals for 3 reasons in India. In India, 65% of the population, even today, is rural, with negligible access to adequate medical care. We do not have enough capacity in public hospitals to handle the burden, Private hospitals are not an option for the average citizen, even in urban areas. And also there is this concern that concentrating large numbers of infected people in small areas, particularly poorly ventilated areas, increases the risk of transmission to other people, particularly healthcare providers, and also increases the probability of emergence of yet newer variants or mutants of the virus that may be more contagious and capable of causing more serious illness. And the reason for this has to do with the inherent biologic property of COVID-19 of reassortment, recombination, and emergence of newer and newer variants, because COVID-19 really is a viral quasi-species with an enormous amount of genetic heterogeneity. So what we need to do is to have a plan to address not only the acute illness caused by COVID-19, but also an ability to address the economic impact of the illness on the patient and the family, the socioeconomic impact of lockdowns, the long-term complications of COVID, particularly lung damage, and in India, infections like tuberculosis and fungal infections. It is my prejudice that in India, we are seeing a lot more fungal infections than, say, in the United States, because there has been probably a much more indiscriminate use of very high doses of corticosteroids in India as part of the treatment for COVID-19. We also need to think about how we're going to address long-term complications of inappropriate treatment regimens of COVID, overzealous use of high-dose steroid, tocilizumab, remdesivir, ivermectin, and convalescent plasma. We also have to think about how we're going to address long-term disability caused by COVID and consequent loss of ability to earn a livelihood. I will tell you, within the last few weeks, increasingly, I am managing a lot of patients. I still do that in Chicago through telemedicine. And more, I'm now seeing patients who have the sequelae of acute COVID infection. They have recovered from the acute illness, but continue to have very troublesome, debilitating illness due to the lingering inflammatory disorder. And this is quite disabling. So what is Share India doing? Share India is a not-for-profit society, which is registered and recognized by the government of India as a scientific and industrial research organization. Most of our work has been providing technical support to the government of India, the Ministry of Health, particularly in the areas of HIV, tuberculosis, and infection prevention and control. So we took our existing programs and modified them to ensure that because of the disruptions caused by COVID, particularly lockdowns, that essential services to HIV-infected patients, particularly the delivery of their medications, which is primarily provided by the government in India, is not disrupted. So we decentralized the dispensation of medications. We ensured home dispensation of medications and also provided logistics support for transportation of medications to decentralized facility. We instituted a program of virtual monitoring and mentoring of the centers that are participating in antiretroviral treatment for retention of our patients on treatment. We provided technical assistance to what is known as the District AIDS Prevention and Control Units on mentoring and monitoring on decentralized dispensation for medications. A lot of micro-planning, route map preparation, provision of vehicles, daily monitoring of decentralized dispensation, and then virtual monitoring and mentoring of all of the centers providing all of these kinds of services to ensure that despite the COVID-induced pandemic and the lockdown, patients who needed desperately their medications did not have their treatment disrupted because of logistics. One of the programs that we have is providing support to the Municipal Corporation of Greater Mumbai and reducing the airborne transmission of tuberculosis in their hospitals. The same program was adapted to ensure that there was TB and COVID bidirectional testing. And this support actually also extends to Dharavi in Mumbai, which is one of the biggest slums in the entire world, where our staff follow patients with MDR and XDR tuberculosis to ensure that their treatment is not disrupted. And during this time, we also tracked people who had COVID and ensured that they required whatever treatment and support they required was facilitated by our staff. We also provided technical support to the government of Mumbai Municipal Corporation in surveillance, epidemiology, and monitoring and evaluation of the data on COVID-19, including those people who had tuberculosis. Today, we are also collaborating with Impact India Foundation, which is a private foundation working in Mokhada and the Palghar district of Maharashtra, where we are helping train community health volunteers to ensure that COVID-related services, both diagnostic and management services, are provided to an entire population of approximately 100,000, primarily tribal people. Through our laboratory support program that we have been working with the National AIDS Control Organization, where we are helping 64 labs across the entire country of India have the ability to do high throughput HIV viral load testing. We started working with ICMR and NACO for including COVID-19 testing on the same platform. So we have helped to train the laboratory staff on safety, use of PPE, infection prevention, control practices. And most of this training was provided on virtual training platforms. And again, providing a lot of mentoring services to all of these institutions to ensure that COVID-related diagnostic services are provided through these laboratories. In Andhra Pradesh in particular, we provided technical assistance for the SARS-CoV-2 testing, and we helped 21 institutions using validated tool, using a lot of WHO tools and IDSP assessment tools. We built the capacity of the laboratories to deal with COVID-19 testing, and then also looking at the way forward, trying to help capacity building of all of the laboratories in implementation of quality management systems in laboratories. The other project that we have, again, funded by the United States Centers for Disease Control and Prevention, is called Bolster. And this program deals with outbreak preparation, working with the district and state disease surveillance teams, providing situational analysis of outbreak preparedness, capacity building, and data collection and use, laboratory surveillance and testing, again with the integrated disease surveillance program, building networks with the virus research laboratories, and also emergency response for infection prevention and control, where we have been assisting in setting up health emergency response centers and capacity building on efficient data usage, training and monitoring infection prevention control in 21 government health facilities in the state of Andhra Pradesh, in particular addressing COVID-19 preparedness and response. So one example is the technical assistance provided for COVID-19 reporting, monitoring, and rapid response in the Mahakumbh, which is one of the largest pilgrimage sites. This year, they had approximately 9 million devotees come to the center. And these are pictures of the control room where the entire area of the Kumbh Mela is monitored by their staff to see what is going on vis-a-vis the COVID situation. And our staff was out there in the trenches with them, helping to monitor the entire situation and also provide technical assistance to the team. Why? The state administration was struggling to integrate the data pipelines and make sense of the data that was being generated in real time. There was no way to assess the quality of data being generated at the call center. So what we did was we provided analytic and epidemiologic expertise through analytic decision support tool creation and a geographic information system mapping of reporting units and facilities. Training on optimum utilization of the health informatics portal. This is a Government of India portal where a lot of data can be used, collated, and analyzed. So we provided a lot of field assistance to the reporting unit. We provided technical assistance to the health emergency operations call center training on ensuring data quality, using a call center dashboard use, and creating databases of photos for potential artificial intelligence-based estimation of adherence to prevention. So this is a map of the facilities that we created a GIS map for, color-coded by the type of facility, whether it's government, private, COVID, layered information, including number of beds available, ambulance services, outpatient services, inpatient services, and testing laboratories. Here's again a series of pictures of the data reporting and monitoring training for the staff that was provided at the Kumbh by my staff, and the call center, emergency operation center in Haridwar. So also providing field assistance for investigation of early warning signs of COVID. So all of these people are working collaboratively over here. And here are some discussions with all of the stakeholders during the Kumbh Mela. And here are pictures of my staff, Dr. Kadrok, Dr. Rashmi Pan, Dr. Anup, Dr. Gursimrat. Dr. Anup is actually an officer of the Centers for Disease Control and Prevention in Delhi. And a couple of other colleagues, Dr. Deepak Rastogi and Prashant Kumar, are not in the picture. Now, what do we think we need to do in India? We need to prevent. What does prevention mean? Prevention has two components to it. One is information management. We prepare, disseminate, translate reliable information to the entire population through a variety of different means, cartoons, videos, social media, billboards. We also need to provide information to promote vaccine acceptance. And the other part is behavior change. And the key here, I think, is to ensure ventilation. Where ventilation cannot be assured, masks are a means of reducing the risk in poorly ventilated areas. Encouraging physical distancing, not social distancing. I prefer to call it physical distancing, understanding that when 10 people congregate together, there's a 30% probability that somebody will get infected. And if 50 people congregate together, there's an over 90% probability that somebody will get infected. Promoting hand hygiene, promoting sanitation, promoting vaccination. Identification needs to be strengthened, a variety of different means. In some places, it is possible to do laboratory testing or at-home testing with antigen, laboratory testing through the nucleotide amplification testing methods or other methods. But very often, particularly in remote rural areas, we have to rely on syndromic surveillance. Stratification of people who may be infected with COVID, looking at their comorbid conditions, looking at social determinants of health, monitoring their vitals, monitoring oximetry, and then looking at markers of inflammation where this is clinically feasible and logistically feasible. In terms of oximetry, we're trying several different approaches, whether people are able to afford personal oximeters, or at least we have the ability to give community workers oximeters so they can assist in a community level monitoring of oximetry for a variety of people. Finally, we do need to both treat and trace both at the same time. We have to stratify people by treatment in the community or in the hospital. Like I said before, it is preferable to try to treat as many people as possible in the community to reduce the demand for oxygen and demand for hospitals. So we are trying very hard to put into place community treatment strategies where people are screened with oximetry, and in those people who are hypoxic, there is an early institution of anti-inflammatories, in particular dexamethasone and anticoagulation, or inhaled steroids like budesonide. At the same time, very important to take into consideration social determinants of health, etc. The next important thing is contact tracing, and this is one area where we do have a fair amount of experience doing contact tracing for the HIV epidemic. And therefore, in addition to the conventional methods of contact tracing, we are also trying to put into place other technologies like digital tracing. The monitoring that needs to be done for all of these people, I think, should include
5 more minutes,
symptoms, and also trying to see how people can be monitored, not only in the hospital, but also at home. And basic monitoring also, we think, should include socioeconomic conditions and economic outcomes and long-term disabilities. And this monitoring should be long-term, certainly more than 6 to 9 months. If possible, and if we have the resources, then I think advanced monitoring would be very desirable, both virologic as well as other infectious disease syndromic surveillance, because we do know that COVID-19 is a profoundly immunosuppressive condition with substantial increase in the risk of other infectious diseases like tuberculosis emerging. And we've also now seen that there are a lot of people suffering from invasive fungal infections. There also is a need to do long-term monitoring for the cardiac, pulmonary, and central nervous system complications of COVID. 30% of all people with COVID infection have cognitive dysfunction, memory problems, and also hypersomnia and insomnias. So we think that a community worker would be an ideal worker to be armed with masks, hand sanitizers, oximeters, dexamethasone, and anticoagulants. And these healthcare workers should be trained to monitor people in the community, looking at oxygen saturation, weight, blood sugar, blood pressure, and also use photo voice to record the personal perspective of illness of the individuals with COVID, their family, and also look at their impact in daily life. Medicity and Hyderabad, which is outside about 40 kilometers from Hyderabad, is a private not-for-profit institution, and they have set up a 20-bed unit, now expanded to 40 beds. And the key thing that we focused over here is to ensure that there is adequate ventilation. As you can see, there are plenty of windows and open doors. There's no air conditioning, they're just fans, but there's lots and lots of open ventilation, and it is at a very low cost, only about 15,000 rupees a day, which is roughly around $200 a day. This compares to private institutions charging about $2,000 a day. So these people are provided oxygen, they're provided dexamethasone, anticoagulation. So that is the end of my presentation. I'm happy to take any questions over here.
Thank you, Dr. Yaldandi. We really appreciate, as always, your presentation is full of wisdom and guidance. What I would recommend, Dr. Governor is already here, so she will also have her presentation, and we will be following it through the question and answer session for both of you, if it is okay with you. So it's now my pleasure to welcome the advisor of today's program, Dr. Sampat Shivangi, who will be introducing our second speaker. Dr. Shivangi is the current chair of the API Legislative Affairs Committee, member of the National Advisory Council, Substance Abuse and Mental Health Services Administration, Center for National Mental Health Services, Washington, D.C., past advisor to the United States Health and Human Services in President George W. Bush's administration, and chair, Mississippi State Board of Mental Health. Before he introduces our second distinguished speaker, I request all of you, please, start typing your questions. So I will be able to pick up at random. I'll try to do the justification for the time too, and then we'll proceed from there. Dr. Shivangi, please.
Thank you, Dr. Murthy. It's a pleasure to work with you. And good evening to everyone. And now it's my honor and the privilege to introduce our speaker, Dr. Celine Governor. Dr. Governor, welcome to API. Dr. Governor is, of course, an American, distinguishing herself with proud two heritages, one Indian American and second French American. Interestingly, her father is Mr. Raj Natarajan from a small village near Erode, Tamil Nadu. And her mother is from Normandy, France. Dr. Governor visits her father's native place and does a lot of charities in Tamil Nadu, a commendable and admirable act. Her background, she graduated from Princeton University, master's from Johns Hopkins, and MD from Washington University School of Medicine. She is a filmmaker, medical journalist, writes for many, many well-known magazines and newspapers, including New Yorker, The Atlantic, The Guardian, Washington Post, Reuters, Bloomberg View, so many others I would not mention. She is a frequent expert guest on MSNBC, CNN, HLN, Al Jazeera, CBS, BBC, MTV, Oprah Prime. In 2017, because of her contribution to medicine and public health, Dr. Governor was named as one of the People's Magazine's 25 women changing the world. No small feat. Dr. Governor is the president and founder of Just Human Productions, a nonprofit organization. She also served in Biden-Harris Transition COVID-19 Advisory Board, along with Dr. Vivek Murthy, who is our Surgeon General. She now serves as clinical assistant professor at NYU. Lastly, in early 2015, Dr. Governor spent many, many months volunteering as Ebola aid worker in Guinea. In between 1998 and 2012, she studied tuberculosis, HIV virus in South Africa, Malawi, Ethiopia, and Brazil. Ladies and gentlemen, here is our distinguished speaker of our own, Dr. Celine Governor. Please give her a warm, happy welcome. Thank you so much.
Thank you very much for having me this evening. I really appreciate it. And I really enjoyed actually watching the latter half of Dr. Yaldani's his presentation. Very interesting to hear how things are unfolding on the ground in India. I've been hearing from relatives, including some who've been hospitalized with COVID, but it's really interesting to hear sort of the complementary expert perspective on what's happening there. I thought we would begin with a bit just of an overview of how we're doing here in the United States with respect to COVID and COVID vaccination. As I'm sure you're all aware, cases, hospitalizations, and deaths have dropped dramatically in the United States as we have scaled up vaccination over the last couple months. At our peak of vaccination, we hit about 4 million doses in arms in a day. And not surprisingly, that rate has slowed as those who were most eager to get vaccinated have been vaccinated. So we now have reached over half of adults in this country are fully vaccinated. And once you include children, we're at about 44% of the population that is fully vaccinated. So that means, of course, 2 doses of Pfizer or Moderna or 1 dose of the Johnson & Johnson vaccine. Now, I think one thing that's problematic about these population averages is that really does miss what's happening throughout the country in more vulnerable populations. We're not a homogenous country, obviously, and that applies to our transmission rates, our vaccination coverage rates. Here in New York City, for example, where in New York State, we have reached about 70% of the population having really received at least 1 dose of vaccine. But if you look at the numbers in New York City, that ranges from 32% of Black adults to over 70% of Asian adults who have received at least 1 dose of vaccine. And geographically, Far Rockaway in New York City, which is the part of the city that was hit hard by Hurricane Sandy, as you might remember, their vaccination rates are only at about 37%. Whereas people living in the financial district, so people living near Wall Street, the vaccination rate is 100%. So the problem with these overall population numbers is they really do mask quite a lot of heterogeneity. And what we are seeing is that in communities where vaccination rates are lower, people are also not as adherent with mitigation measures, unfortunately. They have not continued to mask, if they ever did, at the same rates as they had earlier in the pandemic. And unfortunately, a false sense of security does not protect you against COVID, as we all know. And we are seeing transmission rates and cases, in fact, go up in those communities where vaccination rates lag behind. And so that is quite concerning. We have been looking at what are the reasons people are not getting vaccinated in this country. And it's not a monolith of people. There are different subgroups who have different reasons. You have the enthusiasts, you could call them, the people who are the early adopters of change. And that group, by and large, has now been vaccinated. Those people sought out vaccination, got their appointments, got their vaccines. And so what we have left are a group, a combination of people who are sort of on the fence, more watchful, waiting to see how this plays out, perhaps for friends and family. This is a group for which community norms really will have a big impact on whether they get vaccinated and when. So in other words, if they see people around them getting vaccinated, they're much more likely to do so. If they do not see people around them getting vaccinated, they'll wait. And the major concerns that they will raise in conversation will be around vaccine safety. And again, this is very much a group concern where they will follow sort of the concerns of others in their social group, what's expressed, and when those concerns about safety fall away, people start to feel more secure in their social group, they will as well. Then you have a group of people we call the cost anxious. So these are people for whom it could be financial cost, but very often it's the cost of time, the cost of transportation, the cost of childcare that is a major obstacle. Many of these people in this group work jobs that pay hourly wages. So even an hour or two away from work really has very concrete costs to them. And in part to address the concerns of this group, the Biden administration has made it possible for businesses with 500 or fewer employees, so small and medium-sized businesses, they will get a 100% tax credit for the PTO, paid time off, taken by their employees for the day of vaccination. And in addition, any other days they need to take off due to side effects. So for example, if an employee takes, say, a total of 2 days for the days of vaccination with one of the mRNA vaccines, plus another day or two for side effects, so let's say 4 days, all 4 days would be eligible for a 100% tax credit for the value of that to the employer. And so we really need to be doing a much better job of, one, making sure businesses, small and medium-sized businesses, are aware of this tax benefit, and two, that they are making use of it to encourage their employees to take the time off and do so paid for that time off to seek out vaccination. We then have a third group of people who are lagging behind in vaccination. These are what we call the system distrusters. So these are people for whom it's really a question of trust, either in government or trust in the health system. And so you have a bit of a hodgepodge of people with more conservative political leanings who are less trustful of government. You have people from communities of color that are also less trustful of government, but less trustful of the healthcare system itself. And some of what we need to be doing here is really demonstrating ourselves to be trustworthy. So depending on which sort of flavor of this, that might mean in communities of color, really getting healthcare providers of color to do outreach and to provide information, to provide counseling, to address safety concerns. In more conservative communities where it's a lack of trust in government, this may really be about leveraging the voices of local community leaders who are trusted, who are known faces and quantities. It could be everybody from the local high school principal or basketball coach to the local sheriff or the local family doctor, whoever it is that has that kind of trust in those communities. And then finally, we have the true skeptics who really are not convincible. And fortunately, that is only a small proportion of the people who have not yet been vaccinated. So there is still quite a lot of work to do with the groups that are more convincible, so to speak. And some of that's going to require some time. So next, I also just wanted to cover some of the latest news. So you may have heard today that the Novavax vaccine, which is a subunit protein vaccine, So much more similar in technology, for example, to the hepatitis B vaccine that we use commonly, both here and around the world. That Novavax vaccine, clinical trial data, phase 3 data, looking at the Novavax vaccine in the United States and Mexico found 90% efficacy against COVID, 100% efficacy against severe disease and death. So really quite comparable to the mRNA vaccines. And it's important to note that it was also essentially 100% effective against non-variant forms of the virus. So you really just see a dip in efficacy once you start to have variants like the Alpha or the Delta variants, which is what we've seen, frankly, with the mRNA vaccines as well as other vaccines. So this is all very good news. It's unclear whether the Novavax vaccine is going to be a major player here in the United States. The company has said that they probably will be submitting, if they do, for an emergency use authorization, probably not until September. But we may see the Novavax vaccine used here in the United States, perhaps as a booster shot at some point down the line. But I think big picture, the fact that we have another option on the table that could expand vaccine supply for the rest of the world is really quite significant. I'm not sure to what degree Dr. Eldandi got into some of the news on the Delta variant, formerly known or also known as the B1617.2 variant that first emerged in India. What we are seeing is that this variant is something of a double threat. It is both more infectious. So what we might see as the original R0 or the R0 of the original virus might have been around 2. With the Delta variant, it's probably closer to 5. So significantly more infectious than the original virus and more infectious than the Alpha variant as well. In addition, it does also seem to have immune evading properties where it can evade the natural or the immune response to natural infection with an earlier strain, as well as evade to some degree vaccine-induced immunity, particularly if you receive only one dose of whether it's the mRNA vaccines or the AstraZeneca vaccine. There's a significant drop in vaccine efficacy with only one dose of vaccine. So this is quite significant. And what we're seeing in the United Kingdom, where the Delta variant is spreading rapidly, becoming more and more prevalent, more significant proportion of all COVID in the UK quite rapidly. The UK is pulling back on its second dose delay policy, where previously they had been delaying the second dose so that they could cover a larger proportion of the population with one dose more quickly. But now understanding that there's really not very much protection from a single dose, they are accelerating their vaccination, pulling back on that delay between first and second dose, particularly among people who are over the age of 50 or who have chronic medical conditions that would predispose them to more severe disease. Fortunately, here in the United States, we never did adopt a dose delay policy. And so people who are vaccinated, who've gotten their 2 doses really are well protected against the Delta variant. And so hopefully, we have seen some Delta variant here in the United States, but we haven't seen it take off the way it has in the UK yet. And hopefully are using the original dosing regimen without a delay will insulate us from the worst of that. Also in more recent news, there's been discussion of whether the mRNA vaccines have been associated with myocarditis. And the CDC's ACIP will be meeting to discuss this formally on June 18th. Thus far, there does not seem to be a significant signal of increased risk. So in other words, there is a baseline risk in the population of having myocarditis. We see this every year. We tend to see more myocarditis among males, particularly males in their teens and 20s. It's associated with certain viral infections, for example, enterovirus. And so we are in the season right now where you would expect, even under normal conditions, to see myocarditis at some baseline level. And what we're seeing now, it does not seem to be a signal of increased risk over that baseline level. So when you have such a large proportion of the population that is being vaccinated, we may just be seeing cases of myocarditis coincidentally after vaccination, but that doesn't mean, of course, that there's causation there. It may just be a coincidence of timing. But that is being assessed in greater detail right now. The CDC also recently released guidance with respect to travel. And essentially, if you have been vaccinated, you are protected against COVID, and you really don't need to be worried about traveling safely. However, if you are not vaccinated, the CDC is recommending against travel to areas with very high levels of transmission. So that would include places like India, as well as Brazil. With respect to places that have still significantly high levels of transmission, countries like Mexico or Russia, the CDC is currently recommending that unvaccinated people should not travel unless essential. And then finally, the CDC is recommending that unvaccinated people who are at increased risk of severe disease, so the elderly, people with underlying comorbidities, that they should avoid traveling to places that have moderately high levels of transmission. So that would be countries like Cambodia and Kenya. So unfortunately, especially for this audience, it means that if you are not vaccinated, this may not be the year to be traveling to visit family back home. One of the questions I commonly get is with respect to boosters, and we don't yet know the answer to whether you'll need a booster shot or whether people will need booster shots yet. There are two main reasons we may need to give booster shots. One is if the durability of the immune response, if the immune response begins to wane, at that point, you may need to boost it, in a sense, remind the immune system of what the antigen is, the spike protein. Based on the studies we've seen thus far, the immune response does seem to be quite durable, and we don't anticipate that for that reason, you would need to be boosting anytime soon. However, if we allow the virus to continue to spread, to mutate, for more variants to emerge, we may get to a point in the coming months where we do need to provide boosters to overcome the immunity evading properties of some of these new variants. And there are different strategies that are being looked at. Some of that is simply giving an additional dose of the already authorized vaccines. Another approach is, for example, for the Moderna vaccine to be tailored for the B.1.351 variant or other variants, and whether that would elicit a better immune response for some of those variants. Novavax is also looking at that strategy, by the way, of updating the antigen based on the emerging variants. So we don't yet have a timeline as to when that might be. If that might be at the earliest, perhaps boosters this fall, but it's quite possible it could be quite a while later than that. With respect to children, the Pfizer vaccine has been authorized for use in children 12 and up. Moderna has submitted their data as well. And so we anticipate really getting most of the children 12 and up vaccinated in the United States who are seeking vaccination for them to be vaccinated. I think what we are seeing is that the vaccination uptake mirrors what you see in the parents. So where the parents get vaccinated, the children get vaccinated. Where the parents do not get vaccinated, the children do not get vaccinated. And that's not really surprising. That may change as we get a little bit later into the summer, depending on school attendance requirements, particularly for colleges. More colleges and universities are requiring vaccination of their students. And so I think that may also have an impact on vaccination rates in that population. We are starting to see mix and match studies of different combinations of vaccines. So for example, maybe somebody got the AstraZeneca vaccine on their first dose, now giving, say, the Pfizer vaccine on their second dose. And where we're seeing this most is in countries like the UK, where they have faced some issues with respect to supply, but also there have been concerns with respect to the AstraZeneca vaccine in particular around the risk of blood clots. And so for a number of reasons, some of that having to do with side effects, some of that having to do with efficacy against the Alpha and Delta variants. There are heterologous mix and match vaccine studies that are currently ongoing. Finally, I just want to note some of the news on global vaccine supply. The Biden administration last week announced that they would be donating 500 million or 500 million doses to the global vaccine effort, really leveraging supply from Pfizer and what's being produced at the Kalamazoo, Michigan Pfizer plant. In addition, the G7 has announced that they would be donating or pledging 870 million doses of COVID vaccine. But I do think it's really important to note that that is not nearly enough. The estimates are that you would need really around 11 billion doses to vaccinate the world. And so this is really a drop in the bucket. And the major bottleneck here is having enough facilities to manufacture, having enough raw materials to manufacture, and having the know-how to manufacture. And so they're really, it's not just a question of intellectual property. Some have, talked about the TRIPS waiver. India and South Africa in particular are pushing for a TRIPS waiver, which would allow, would give the right to produce, for example, the mRNA vaccines without necessarily licensing the technology from Pfizer or Moderna. But that only gets you so far. Having the right to produce does not allow you or make it possible to produce. That really does require some of these more operational aspects to be addressed. So again, the manufacturing facilities, the materials, the raw materials, the manufacturing know-how, knowing what the actual recipes and processes are. And so that's where we need to be turning our attention, is really to making sure that there is that capacity around the world. And I think the Serum Institute is a good example of really amazing capacity, but it certainly is also an Achilles heel when you find yourself without the ability to export vaccine out of the country, when you have, you're not able to get the raw materials into the country to produce. And so we really need to be building resilience globally by scaling up our manufacturing capacity around the world. So on that note, I'll stop there and turn it back over to you.
Thank you. Thank you, Dr. Governor, for such an excellent and informative update. Definitely the information you provided today will add the new evidence-based information to what we have gained previously through several of the COVID-19 workshops that were given by COVID-19 experts like you. And thanks again for accommodating your time. At this point, what I would like to do is open the question answer session. And unless it is specifically directed to one of you, I would will be non-specific. One of you or both of you can answer that question. So there are not too many questions, but I'm sure we have enough time to cover not only those questions, but definitely we will take a few more questions depending upon the time factors. This is, what is the exact dosing of dexamethasone you recommend? There are two questions. The second one is, how effective are the current vaccines for the new strains? So let's talk about the efficacy of the current vaccines for the new strains first. That is a global question. Thank you.
Well, I'll touch on that briefly, and then I'll turn it over to Dr. Yaldandi as well. The good news is that the vaccines that we have that we're using here in the United States, the Pfizer, Moderna, and Johnson & Johnson vaccines, and for that matter, also the AstraZeneca vaccine, these vaccines remain quite effective, especially with respect to severe disease, hospitalization, and death. They do not prevent all infection with the variants. And so you do see a reduction in vaccine efficacy, in particular with milder forms of infection. But ultimately, the purpose of vaccination is really to save lives. And from that perspective, all of the vaccines that we are using here in the United States and in Europe do remain quite effective against the variants. Dr. Yaldandi, did you want to touch on that as well?
I would echo what you were saying. I think that the important thing is for everybody to understand that the faster we get the people vaccinated, the lower the probability that we will deal with a virus population with greater and greater number of escape mutants. So that's the key message to get across to people. And that's what I tell people. So the best vaccine is the fastest, earliest vaccine that you can get.
And then with respect to the dexamethasone question, so at least with, if you look back at the recovery trial where this was studied formally, the dose of dexamethasone that was administered orally or intravenously was 6 milligrams daily for 10 days. And then they also looked at, in pregnant and breastfeeding women, prednisolone, 40 milligrams given by mouth per day.
So I think there's a long history. So the first fundamental question to understand is, why are we using steroids, right? Is it an anti-inflammatory or are we trying immunomodulation? There is absolutely no evidence that using steroids in doses greater than 40 milligrams of prednisone or equivalent, or say 6 to 8 milligrams of dexamethasone, improves their anti-inflammatory effect. But there is evidence to suggest that you start running into complications such as the undesirable metabolic side effects and greater immunosuppression with the higher doses of these steroids. Now, pathophysiologically, the reason why dexamethasone would work, in my opinion, is because dexamethasone helps to tone down the macrophage activation syndrome that we see in these people. And there is absolutely no evidence, none whatsoever, that giving anybody with a macrophage activation syndrome high dose steroids is better than 6 to 8 milligrams of dexamethasone a day. And my personal prejudice is, I don't have data to back this up, but my personal prejudice is that part of the reason why we are seeing much greater numbers of opportunistic infections in India, particularly the invasive fungal infections, is a very enthusiastic, over-enthusiastic use of very high dose steroids. I mean, I've heard horror stories of people getting 500 milligrams of methylprednisolone a day, which is just astounding. And by the way, by the time somebody has received 6 milligrams of dexamethasone and has not improved, we need to think about doing other things. And unfortunately, we still do not have enough good clinical trial data to tell us what would be the best regimen, and that has to be individualized. But I would strongly discourage anybody from thinking that higher doses of dexamethasone are going to be better.
Dr. Yaldandi, what do you think about the unmasking of latent tuberculosis infection in India if the steroids are indiscriminately used?
So I think that is in India, even without steroids, COVID in and of itself is profoundly immunosuppressive. What we see in COVID is that there is a very sharp decline of CD4 cells and also natural killer cells. And I have personally seen 2 patients that I've been managing in my practice who reactivated tuberculosis as a consequence of acute COVID infection and required treatment for tuberculosis. And anecdotally, I've heard from a lot of critical care people that I consult with that they're seeing a lot of tuberculosis also. So I think that high dose steroids are, for several reasons. A, they do complicate the immunosuppression that we see with COVID. Also, I think high dose steroids make diabetes much worse. And we know for a fact that COVID increases the risk of people developing diabetes de novo, diabetes mellitus de novo, even in people who never had diabetes before. Diabetes is becoming much worse in people who have diabetes pre-existing. And we have known for a very long time that there is a bidirectional relationship between diabetes mellitus and tuberculosis. So this is a major problem in India where we have one of the highest rates of latent tuberculosis in the entire world.
Thank you. To answer the next question, I hope, Dr. Eldandi, you brought your crystal ball with you. The question is, what do you think about the possibility of the third wave in India and whether we can time its occurrence or severity?
So I think that I'm going to quote Yogi Berra, who said that prediction is a hazardous business, particularly when it's about the future. So, and one thing that we have learned is almost all projections that we made, we don't make predictions. As scientists, we do not predict, we project. The projections that we showed for last year, as I showed you, our data was overly optimistic. And at that time, we were being criticized for using an R0 of 3, which everybody said was not true. R0 did not exceed 2.5 and so on and so forth. In retrospect, the R0 of 3 was actually overly optimistic. And if you think about, and the way we do this epidemic dynamics, there's a lot of very complex mathematics that goes into it. And I'm not a mathematician. All I can tell you is that even using a simple logistic map equation, one can see that the moment you start hitting an R0 of 3.4499, that the epidemic becomes cyclical. So whether you call this a third wave, second wave, first wave, fourth wave, nth wave, I think that's semantics. The reality is that at such a high rate of replication, such a high reproductive rate, you are going to see the epidemic cycle. So there will be a dip in the number of cases that we see. How deep that dip will be, how deep that trough will be, followed by how steep the increase is and how high the peak goes, is at this time a matter of speculation. But I personally think that all of the evidence that we have seen to date globally suggests that the epidemic will become cyclical and will be cyclical for quite some time to come.
The next question is to both of you. I guess this is an evidence-based informational question. With the so-called Delta variant strain from India, I would add elsewhere, taking the main focus truly how safe are these vaccines and what prevention protocols are to be placed. Anything different from what we are already doing?
With respect to mitigation measures, it's really the same. I think I really appreciated this as somebody who worked in TB or has worked in TB for many years. Ventilation. And I don't think we make enough use of that in more developed settings. And it's really to our detriment, frankly, because it is cheap and highly effective. So I love those pictures of the hospital wards, with all of the cross currents and the windows open. I think that's something we really need to be also improving in places like the United States. I think we really need to be doing a lot more in terms of ventilation than we are, and relying relatively, less proportionately speaking, on personal protective equipment. Personal protective equipment is really meant to be what you do to mop up what you don't get through more effective means like ventilation. But it's the same mitigation measures that work for whether it's the original virus or any of the emerging variants.
Thank you. The next question is from one of the eminent research professors, and this is regarding the long-term follow-up at Hyderabad in adults and children, if at all there is any protocol in place? I guess Dr. Eldandi, can you please?
So this is one place that I think our learning has evolved. Last year, when I was treating people, I would say, look, we'll give you anti-inflammatories, and once you are clinically better, the clinical illness has resolved, you can rest assured that you will be okay. There will be a variable period of convalescence, and then eventually the prognosis is good, you will all recover. This year, I have changed my method completely. I insist now that everybody is monitored by use of the inflammatory markers, specifically C-reactive protein, ferritin, and D-dimer. And I continue to monitor them weekly, even after their acute clinical illness has resolved. And the reason for that, what I have seen is in those individuals where even when they're recovered from the acute illness and relatively asymptomatic, once their ferritins and CRP start climbing, they eventually become symptomatic. And one needs to resume the anti-inflammatory treatment to help control their symptomatology. The other part that is very, very troublesome is that not everybody is symptomatic immediately after infection. It's very variable. Some people are symptomatic several weeks after the acute infection. And some people have very troubling, disabling complications. So that it requires closer monitoring. And this is why I'm encouraging everybody to monitor the serum markers for several weeks in the acute period, and thereafter by symptom monitoring for several months, 6 to 9 months at least.
What do you think, Dr. Governor, from the United States perspective?
Mm-hmm. With respect to, sorry, what exactly?
This is regarding the why this we're talking about the long-term follow-up. He said he asked for Hyderabad specifically, but I'm also adding a little flavor by asking, do you know anything about any of the studies going on for the long-term follow-up? Well, the definition of the long-term is ambiguous.
Yeah.
100 years, 50 years, 10 years. So I think, with the fact that facts we have for the past year and a half or 2 years, so I still think it is an intermediate term follow-up, but it could be long-term if this is the end of the epidemic. So what do you think of any of the studies that are brewing for this type of intermediate term follow-up in the United States?
Well, there are a number of what we call long COVID clinics that are popping up around the United States where patients are being enrolled into clinical trials, looking at repurposing drugs, also looking at what is the impact of vaccinating somebody who has long COVID. One of the immunologists who's doing some of this work, Akiko Iwasaki, has posited that there are a number of different ways in which people may have these long-term symptoms. It could be that you have ongoing replication of the virus in immunoprivileged sites at low levels. This is something we see, for example, with HIV, where you may have low-level ongoing replication in places like the brain, where you have mutations of the virus occur in relatively more immunoprivileged protected sites. In the case of HIV, where the antiretrovirals don't penetrate as well. You may have a similar phenomenon with COVID, where perhaps in the brain, perhaps testes, some of those other places, bone marrow, where you could have some low-level replication that's also contributing to ongoing symptoms. Another theory is that you have traces of virus, whether it's protein or RNA, that's not live virus, but that is still eliciting an immune response. And then a third theory is whether it's an autoimmune response that's being triggered by the virus. But there are a number of people whose symptoms have improved with vaccination, which may point towards the first two hypotheses as being what's behind long COVID. And that is being studied here in the United States in a number of places. And unfortunately, I am going to have to hop off. I'm so sorry. But it was really a pleasure to be here with all of you today. Really fascinating to hear how things are going in India, not just from my family's lay perspective, when I hear from them, but to hear from experts like you, who can really attest to what's happening. So thank you for what all of you are doing, and thanks again for inviting me.
Thank you, Dr. Governor. Before you leave,
few minutes, a few minutes, go ahead.
we are truly honored with your presence today, and thanks again, for accommodating us with your busy schedule. I request Dr. John Laganda to recognize and honor and induct her to the API Distinguished Speakers Club, and then we'll proceed with Dr. Eldandy's the rest of the questions and answers.
Thank you, Dr. Governor, for his eloquent talk on updates in the US. And Vijay, can you put the slide on, please? American Association of Physicians of Indian Origin recognizes Celine Governor, MD, SCM, FIDSA, for her outstanding contribution in the field of infectious diseases, and welcome her as a member of AAPI Distinguished Speaker Club, President John Laganda, Dr. Veman Murthy, Chair of the committee. Thank you very much for joining today. Thank you.
Oh, thank you. It's such an honor. Thank you so much.
Thank you, Dr. Governor. Good to see you.
Dr. Governor.
Bye.
Now we will be resuming the rest of the session with the questions to Dr. Eldandy. Okay. This is actually a global health question. And Dr. Eldandy, being an international public health person, I think, why China has not suffered from the incidence and mortality as the most of the countries in the world. China is 99th compared to many countries, especially when you compare the size of the country. Dr. Eldandy.
I don't know that we know exactly what is happening in China. And, as the last year has demonstrated, whatever official proclamations come out of China, we've all learned to take with a grain of salt. So that said, as a preamble, what I would suggest to you is that India is a very chaotic situation. All right. India is a very diverse country, very diverse belief systems, very diverse practices, and extraordinarily difficult to persuade anybody in India to do what we think is most appropriate vis-a-vis the epidemic control. Okay. Now, China, I think people have commented that China, being a much more regimented society, that they have, the government at least there has the ability to enforce their diktat much more forcibly, particularly when it comes to matters of non-pharmacologic interventions, which is physical distancing and segregation of affected peoples, lockdown, so on and so forth. And perhaps that is a factor there. But lately we've been seeing that now China in some areas has reported that they have an emerging problem. They are grappling with a sudden and unexpected increase in the numbers of COVID. So I think that regardless of what one thinks about the desirability of using very draconian measures to control social interaction, one has to factor in the basic biology of this virus. It is very different. So the fact that to date, China has had a better control of the epidemic does not necessarily guarantee that the same method would produce like results in the future, either in China or elsewhere in the world. And being in public health for such a long time, particularly in HIV, I have a very severe distaste for any coercive measures. I think they're counterproductive in the long run, and I would strongly advocate against that kind of a coercive, regimented system of addressing any epidemic.
Thank you. There are a couple of questions about the Novavax. The first question is, why would Novavax be used as a booster shot than Pfizer or Moderna. The second one is about how do you store this vaccine?
So Novavax, being a protein subunit vaccine, does not have the stringent temperature storage requirements that the mRNA vaccines do. So it's logistically a little bit easier. Okay. As to why a heterologous platform would be considered appealing, immunologically, the thinking behind that is that you would stimulate different aspects of the immune system and therefore get a much more robust and rounded response in terms of vaccination. Again, all of this is very uncharted territory. And I think when you look at the basic biology of the virus, all of this is very simplistic thinking. So this needs to be borne out by large scale clinical trials to see if what we think intuitively or conceptually might work actually really does work in the field.
Thank you. The next one is a very interesting question. Obviously, if you have received 2 doses of the vaccine in the United States and you want to go to India, what is the current recommendation? Do you need to have a so-called India-specific vaccine? I guess, the question is asking about the Indian variant, so is it necessary to have a vaccine in India?
The short answer is that to date, the data that we have seen is quite encouraging in the sense that at least the mRNA vaccines and the Johnson & Johnson vaccine appears to confer immunity and some protection against the Delta variant seen in India in terms of reduction of mortality. That does not mean that your risk of getting infected is the same as your risk of getting infected with other variants. There is, it appears, a difference in the risk of getting infection. So the risk of getting infected with the Delta variant that is found in India is higher than other variants, despite the mRNA vaccines that are being used in the United States. So, and anecdotally, I've heard of several visitors from the United States coming to India who got infected and did become clinically ill. Fortunately, most of them survived with rare exceptions. So hopefully that remains true. There is also good data to suggest that transmissibility of infection is reduced by these vaccines. So all in all, both for anybody as an individual and also in the public health perspective, it is desirable to have the vaccine, the Moderna or the whatever vaccine is available in the United States, because all of them seem to have some efficacy against the Indian variant.
I have 10 more minutes left, because we started the program and 10 minutes have been utilized for the introduction and all that, which is not a part and parcel of the CME process itself. So I will just go fast. This is about the optimum time to get a booster dose after the second dose of vaccine.
So we don't know for sure, but what we have seen in the data so far is that measuring immune responses to the vaccine in terms of the antibody titers and also protection from acute illness seems to last for at least 9 months after the second dose of the vaccine. The question...
Go ahead, please, I'm sorry.
Yeah, the question is, will we see a decline in protective immunity over a period of time so that a booster dose is required? Now, that's one question. And the second question is, what will happen to the predominant variants that are circulating in the population a year hence? And will that necessitate a different vaccination strategy for that? Just like we do with influenza, where we are monitoring the emergence of different influenza types, and therefore the vaccine is tailored year by year as to the predominant type of vaccine circulating in the population. So those are still unanswered questions.
The next thing is, should we get antibody test before the booster dose?
I don't think that it makes sense immunologically because the protection that is conferred against the infection is not simply antibody mediated. There are a variety of different types of protection. Firstly, if you think about generically any kind of protection against a viral infection, there are three different arms to it. One is innate immunity, which is what we are all born with. And the second one is the adaptive immunity, which is both cell mediated as well as antibody mediated. So, in terms of measuring antibodies, and again, which antibody are you measuring? Antibody to the vaccine-related immune response is the spike protein antibody. The native infection would be slightly different. There we are looking at the nuclear antigen. And again, my concern here is that we rushed into the market with a lot of these antibody tests without adequate validation. So and clinically, I've seen that there are many instances where I am having trouble interpreting what these antibody tests mean.
Thank you. I think the next question also it pertains to the China, the statistics that is emanating from United States and India. I think he's talking about the total incidence of mortality. UK is 7th. Despite its size, China is 99th. So how do you explain the significant disparity in this instance? I know you partly answered this question before. So if you would like to add anything to your previous.
See, I think that even if you take their assumptions and their data and their reporting at face value and assume that everything is really true, verified, accurate, the only thing that you can say is that, look, they probably have been more successful at employing non-pharmacologic interventions much better than many other places have been. So that would be one potential explanation for why things are not much worse than they appear to be in China. I don't know of any other factors because one needs to see what will happen over a period of time. Again, like we are seeing in the UK now with the increasing numbers of the Delta variants in UK, again, the epidemic trajectory is changing even there. So again, like I'd go back and say what Yogi Berra said, predictions are hazardous, particularly about the future.
As I understand, the next question is regarding the autoimmunity with mRNA vaccines when compared to the other vaccines. I mean, I guess he's asking about the magnitude or the amplitude of response,
Yeah, it seems at least in a small, very, very, very small minority of individuals, there seem to be differences in various kinds of vaccines in terms of what is happening in terms of an aberrant immunologic response to epitopes of the virus. For example, Johnson & Johnson vaccine, people have noticed that they have vaccine-related increased thrombotic episodes. Israel has also noted some vaccine-related, and this is mRNA vaccine-related increase in young men of cardiac involvement. Whatever we think about how reliable that data is and how able we are to discriminate against the background noise that occurs during this time of the year in terms of other viral infections causing myocarditis. The entire question of what is autoimmune, what is aberrant immune response, what are differences in immunologic responses due to underlying genetic heterogeneity in the innate and immune response is a very complex question. And you will find that there is a lot of heterogeneity in what is happening. For example, we know from fact that people who have toll-like receptor 7 mutations have a very high mortality due to COVID-19 infection, even with the alpha variant. So this is something that requires a lot more detailed study.
Thank you. The next question, we know that there were deaths after the second dose of vaccine due to the infection, per se. Here the question is, were they immunosuppressed? Well, actually, the question is, has there been any deaths after the patients had received the second dose of vaccine? We know that there were cases. Now, some of these patients were immunosuppressed, or, I mean, what is the
So I think that is again something that requires more data and evidence. So the key questions one asks is, did they get into trouble and have a bad outcome because the vaccine failed? And we know that not in some people the vaccine does fail because they have underlying immune defects, either acquired or iatrogenic, as in transplantation. We know that vaccine does not have uniformly similar efficacy across the board, and that's true of all vaccines, not simply COVID-19. Any vaccine has a lower efficacy in the extremes of age as well as due to underlying immunological deficiencies.
what's the
Now,
I'm sorry, go ahead.
so early in the epidemic, there was some concern about a phenomenon known as antibody-dependent enhancement, where we see that those people who actually have an immunologic response to a infection, once they get the wild-type infection, have an exaggerated clinical illness. And that's particularly true, for example, in dengue. And the prior infection sensitizes, the next subsequent infection causes a much more severe illness that causes mortality. To date, we have not seen the antibody-dependent enhancement in any significant numbers due to COVID-19 that we were concerned about. Nevertheless, it does remain a conceptual, theoretical possibility.
Before I pose you this next question, and I request all the participants not to post any more questions because we are running really out of time. So Dr. Eldandi is trying his best to accommodate the time process. And so, just bear with us for this. The next question is, what is the vaccine that you recommend for patients above 100 years of age?
Whatever vaccine they can get the earliest. We don't, at the present time, have any data to suggest that that people over a particular age should have a difference in the approach to how we manage this epidemic. So I would say that age is just a number. And the fact that somebody is over 100 does not automatically mean that they will not respond to a vaccine or they will respond to a particular type of vaccine in a different way. So I would suggest that they should all be vaccinated. I made sure that my 92-year-old father got vaccinated.
The next question with a quick answer, the efficacy of doxycycline or minocycline in a symptomatic COVID-19 patient.
0.
Okay. Thank you. So what's the dose of anticoagulant after hospital discharge and for how long?
So there are two ways to approach this. In somebody who has had an actual complication, a thrombotic complication, a venous thromboembolism, we recommend that they receive anticoagulation for at least 3 months after that episode. For people who have not had any venous thromboembolism, probably much shorter duration should be fine. The way I have approached this is I keep them on an anticoagulant until their CRP and D dimers have near normalized, or at least their CRP has completely normalized. Is that absolutely essential? Is that advantageous? We don't know. I don't have data to tell you exactly what is the correct approach. We do have data to tell us very clearly that there is no advantage to going to full dose anticoagulation as opposed to simply a prophylactic dose of anticoagulation. And it doesn't really matter what you use, whether you like heparin or you like a direct oral acting anticoagulant. It's very convenient to use, at least in India, either apixaban or rivaroxaban because you don't need monitoring. And people hate getting hypodermic injections. So that's practically what we use. Do not exceed the prophylactic dose. There is no advantage to going to full anticoagulation.
The next question is about, I guess, about the relatively increasing prevalence of mucormycosis in India. Why?
So I don't have clear evidence to tell you exactly why, but I will tell you that anecdotally, I have also seen people without any prior risk factors like either type 1 diabetes or leukemia getting sino-orbital mucormycosis. And these were people who were not treated with high-dose steroids, okay? So clearly COVID in and of itself is a risk factor for invasive fungal infection. And like I said, COVID is known to cause the CD4 cells to decline. So it's very reminiscent of how HIV causes trouble. Now in India in particular, why we are seeing a whole lot more of these invasive fungal infections, my prejudice is this is a consequence of indiscriminate use of very high dose steroids and also tocilizumab. And also the fact is, if you've ever gone to any Indian hospitals, what you will notice is that the physical plant is very dirty. They're grimy. And if you see any false ceilings out there, I will guarantee you those false ceilings have discoloration due to water damage. They are black, brown, and those false ceilings have an extraordinary high amount of environmental molds like Aspergillus, Alternaria, and Mucor. So I'm not surprised that people are exposed to very high environmental levels of fungal spores in India in Indian hospitals.
Thank you. The next is regarding the I think, common persistent symptom of loss of taste after the COVID-19 infection. So the question is
See, I think that this, like I said, central nervous system complications of COVID are very, very common. 30% of people with COVID infection at least have severe cognitive dysfunction. And we've seen a lot of variety of different central nervous system complications, including anosmia, ageusia. Some people have Guillain-Barré, some people have actual encephalitis, and a lot of insomnia, headaches, very troublesome. And whether this is a consequence of direct neurotropic viral infection or a antibody mediated or immunologically mediated disorder is something that is not very clear to me. I think that early on it is clearly a neurotropic viral infection, because we know that the olfactory system is a portal of entry for COVID-19. So early on, that is easy to understand why there is so much anosmia, ageusia. Why this continues and persists for long periods of time in some people is a little different. And I think that the pathogenesis there may be very different. Particularly the pathogenesis of encephalitis may be very different.
Thank you. I got two more questions. One has received 2 doses of vaccine, and can he or she visit grandkids under 11 years?
The data that vaccination reduces risk of transmission is very clear. There is at least a 50%, if not greater, reduction in the risk of transmission of virus. So I think that, I would not constrain somebody from visiting their grandchildren if they have already been vaccinated, for 2 reasons. A, the vaccine efficacy reduces risk of transmission, and B, children, even if they do get an infection, have a much milder illness, so they don't have as much trouble. And I would hate to deprive the children of that kind of social interaction.
Thank you, Dr. Laganda. This is our last question. After getting AstraZeneca as the first vaccine, can a Pfizer/Moderna as second dose be equally effective?
In all likelihood, yes. Conceptually, intuitively, based on the basic science, I think yes. But in terms of data to support that contention, that is still awaited, because those kinds of studies, particularly in the UK, are ongoing to see what is the consequence of a cross-platform strategy of vaccination.
Thank you, Dr. Laganda. We can't thank you enough for your presence here and your wisdom and your practical experience. And you filtered your experience and converted it into a reality. Before I request Dr. John Laganda to honor Dr. Vijay Laganda, and this is directly, I'm addressing all the participants. Also, the participants who are not here today, and I think, from the bottom of my heart and on behalf of our committee, we thank you. We thank you for your participation and support of the API webinar CME program of this year. So at this point, I request Dr. John Laganda to have the honor bestowed on Dr. Vijay Laganda. Dr. John Laganda, please.
Thank you, Dr. Laganda. What a great talk. And also thank you for taking the time to answer all the questions of members. Indeed. And Vijay? The American Association of Physicians of Indian Origin recognized Vijay Laganda, MD, for his outstanding contribution in the field of infectious diseases and welcome him as a member of API Distinguished Speakers Club. Sudhakar John Laganda, MD, President, Vemuri S. Murthy, Chairman, API Webinar CME Committee, June 14, 2020. Thank you very much. Also, I want to thank you, Dr. Sampat Shivangi, and also our chair, Dr. Vemuri Murthy. What an outstanding contribution for our organization and bringing one of the world-class speakers for this same webinar for this 12 months. Okay. Thank you very much, sir. And also I request all the members, please register for 39th Convention of API in Atlanta, Omni CNN. And today is a deadline for early bird. And please register and support the organization. We'll have exciting programs, CME, and also entertainment lined up for you. And you all stay safe. And by the way, in Atlanta Convention, we are following CDC guidelines still. Okay. Thank you.
I just want to say thank you, Sudhakar. You've done an outstanding job, along with Dr. Vemuri Murthy and Dr. Vijay Laganda's oratory was outstanding. He's so knowledgeable, my God. If I'm going to be sick, I'll come and see you, Dr. Laganda. I'm so much impressed. Thank you for bringing him. And of course, Dr. Governor was also outstanding. And we are all thankful to API and President and his team. Thank you so much.
Thanks again. This concludes our CME program. Good night.
Thank you very much for the great honor. Thank you. Bye.
Good night.